Good evening, everyone, and a very warm welcome to one and all. This is Dr. Komal Shah, and I'm joining you all from the beautiful city of grapes, Nasik. And today, I'm extremely happy and excited to share this news with you that CCI is starting a webinar series on the topic which is very close to my heart, pulmonary infections. And I, along with Dr. Atri Gangopadhyay, have the privilege to be the course directors for this entire webinar series. So let me tell you a little bit about this series. We have designed it in such a way that we have tried to include all the organisms in different way. It is going to be the out of box series. For example, if we are taking today community acquired pneumonia, hospital acquired pneumonia, and ventilator associated pneumonia, we are not just going through the theory or guidelines. We are going to go beyond books. We are going to discuss that these guidelines are there, but how do we inculcate them into our day-to-day practice in context with Indian scenario? Same way we have other lectures like fungal pneumonias. So here we will be discussing fungal infections in healthy and immunocompetent host, which is now new thing. Same way in viral infections, we will be discussing that how we can differentiate viral infections from a hyperinflammatory state from secondary bacterial infections. We have also included topics like atypical pneumonias and pneumonias in special host, immunocompromised, and post-transplant infections. And not to miss, we have also included newer diagnostic modalities, be it imaging, be it focus, be it intervention pulmonology, that how can we use the intervention pulmonology in diagnosis and therapeutic as well. One very important topic is going to be on molecular diagnosis. We must know about the different multi-drug resistant organisms. How do we diagnose them and how do we treat them? And the final part is going to be a grand finale where we will be having our experts from the fraternity who will be discussing on very interesting cases. So this is how we have tried to divide the entire pulmonary infection thing. We have not included tuberculosis in this because for obvious reasons, tuberculosis itself is a huge topic and we'll be coming up with that series as well. But for now, in pulmonary infections, let us know if you want to know about, like, if you have more thoughts, if you want us to discuss something more, please, you are free to mail us or WhatsApp us. So before that, let us begin with today's session. And before that, let me thank the entire CCI community. Dr. Krishna sir, Dr. Pradeep Narayana sir, and Dr. Anil Maske, Dr. Dubey, Dr. Ravi Doshi, Dr. Atri sir, and of course, Dr. Chilamchetti sir. They have been working tirelessly to make CCI the best platform for the pulmonology community as a reliable source for academics. And with that introduction, let me start with today's session. And I would like to introduce our panelists today. We have very highly professional academics here. So I'll start with the captain, the first player, opening batsman of our team, that is Dr. Ambika Sharma. She is a very dear friend of mine. Currently, she is assistant professor at SMS Medical College, Jaipur. She has completed her MBBS, DTCD, and DNB. She has multiple awards on her name and almost 24 publications with 8 chapters. She is also editorial board member and reviewer for many national and international journals. Welcome, Ambika. Then we have Dr. Arnab Bera. Sir is consultant respiratory medicine at Manipal Hospital. He's completed MBBS, MD, DNB pulmonology, and he is the only intensivist here. He has done FNB critical care. Welcome you, sir.
Thank you.
We have Dr. Abhishek Agarwal with us. Sir is HOD in intervention pulmonology and sleep medicine at Dispur Hospital, Guwahati, Assam. He is also secretary of Northeast Sleep Society, state head of Chess Council of India, Assam. He is treasurer of Northeast Respiratory Society and national trainer in National Tuberculosis Elimination Program. We welcome you, sir. Next is Dr. Utkarsh Gupta, sir. He is consultant and head at Heritage Hospital, Noida. He is MBBS, MD, and fellow in sleep medicine. He's received multiple awards. He's also received Allied Gold grading by ICMR for TB, and he's got numerous publications on his name. We welcome you, sir.
Thank you,
And
Dr.
finally, we have Dr. S.T. Madhukar. Sir is the director and consultant at Madhukar Clinic and Lung Hospital, Patna. He's got gold medal in MBBS, Best Postgraduate Thesis Award, and also has fellowship of ICS in 2023. He's authored many books and multiple publications as well. Thank you. We welcome you, Dr. Madhukar. And with that, let us start with our first talk by Dr. Ambika Sharma.
Good evening, everyone. Thank you very much, Dr. Komal, for your kind introduction. At the outset, I would like to thank Dr. N.H. Krishna sir, Dr. Atri, Dr. Ravi Doshi, Dr. Vijay Chinnam Chetty sir, and office bearer of CCI for giving me this opportunity to speak on such an important topic, which is community-acquired pneumonia. So this is a huge topic. I would be touching on very important aspects only, and mostly the clinical and practical aspects which are related to the guidelines. Let's start with the case. 50-year female, hypertensive, comes to the OPD with complaints of cough, fever, sputum production, throat pain from 3 days. Her husband also has similar complaints. On examination, her temperature was high, which was 102 degree Fahrenheit. Pulse was 110 per minute. Blood pressure was normal and respiratory rate was 24 per minute. Her chest revealed right-sided basal crackles, and this was the chest X-ray which was done for her. So this is a case which we come across every day in our OPD, and we wonder, is this a pneumonia? So before understanding is this a pneumonia, it is important for us to first understand what pneumonia is. Pneumonia is actually the inflammation and consolidation of lung tissue due to an infectious agent. Traditionally and clinically, we have been diagnosing pneumonia if we say there is the presence of 2 or more of the following sign symptoms, which are cough, sputum production, dyspnea, tachypnea, fever, chills or rigor, or pleuritic chest pain in conjunction with the new opacity on chest radiograph. So there are many ways pneumonia can be classified. We are discussing today about the clinical classification, which is community-acquired pneumonia or CAP, and it is defined as acute infection of pulmonary parenchyma, which occurs outside the hospital settings. There are many patients who are at risk of developing pneumonia, and we need to understand and know them before diagnosing these cases. These are the elderly, patients with the history of smoking and alcohol, patient with impaired airway protection, any patient who had has recently got viral respiratory tract infections, especially with influenza, they are more prone to get the bacterial pneumonia. Patients who have comorbidities like chronic lung disease, liver disease, kidney disease, or cardiac disease, or immunosuppressive drugs, or any of the disease which is causing immunosuppression, they are at the risk of developing pneumonia. And there are some patients who live in the crowded living spaces, they also are at the risk of developing pneumonia. So what causes pneumonia? It's been since many decades, Streptococcus pneumoniae has been most common causative agent for pneumonia, and then there are the viruses. And if we divide the causes of pneumonia with the bacteriology, so there are the 2 groups of bacteria. They are the typical bacteria, which usually present the typical signs, symptoms, and radiological presentation. They are the Streptococcus pneumoniae, Staph aureus, and the atypical bacteria, which are Legionella, Mycoplasma pneumoniae, Chlamydia, and Coxiella bagnati. They are the respiratory virus, which also present little atypical in presentation for pneumonia, and these are the influenza A and B, parainfluenza virus, coronavirus, rhinovirus, adenovirus, human metapneumovirus, and respiratory syncytial virus. There has been a little change in trend of the etiology of pneumonia. What we are seeing over the years, that there is a little decline in the Streptococcus pneumoniae incidence, although still today it is the most common cause of community-acquired pneumonia. Then we know that we have seen in COVID-19 pandemic, where all causes of pneumonia was due to the virus, which was coronavirus. And we should also understand that after COVID, we have become more wiser in diagnosis, viral infection. We have been now using PCR, biofires, and we are coming across new respiratory viruses which are causing the pneumonia. We should also be aware about a lung microbiome, because lung is no more considered a sterile organ. So in lung also, a tracheobronchial tree alveoli, they are the few pathogens which are normally found and should not be considered for pathogenic pneumonia. So after the etiology, we come across the important practical aspect of diagnosing pneumonia. And when we are talking about diagnosing pneumonia, we keep two things in the mind: what is the clinical presentation and the radiological collaboration. Among clinical presentation, patients will have characteristic symptoms of fever, chills, pleuritic chest pain, cough, which can be productive, non-productive, and shortness of breath. Not to forget, some of our pneumonia patients can have non-respiratory presentation, especially patients with mycoplasma pneumonia or atypical pneumonias, where they can present as headache, nausea, vomiting, abdominal pain, diarrhea, myalgia, and arthalgia. If we do the examination of this patient, we will find that they are febrile, their tachypnea is there, tachycardia is there. On a physical finding, we can find the consolidation findings, which are bronchial breath sounds, crackers, bronchophony, and whispering bacterial leaking. So after the clinical thing, we need a radiological confirmation of pneumonia, and then we have three options. Should we go for chest X-ray, CT scan, or there is some new test, which is ultrasound of the chest, which can be utilized for diagnosis of pneumonia. Let's see what the evidence says. If your patient is an outpatient cab, you can go for the chest X-ray, or you can use USG chest, but this should not delay the antibiotic initiation, and patient can have a normal looking chest X-ray or sonography chest, even the patient have a pneumonia. So, but if the patient is admitted, whether it is severe or not severe, one should go for a chest X-ray or ultrasound chest, and CT scan should be done only when there is a doubt. So when we are talking about radiology, whether it is chest X-ray or CT chest, we have a certain patterns which we see to confirm that this looks like pneumonia, which is consolidation, lobar pneumonia, or focal opacity, which is predominantly seen in typical pneumonias caused by typical bacteria, which is Streptococcus pneumoniae, Klebsiella, and cavitation. If we've seen with consolidation, we should think about Staph aureus, necrotizing pneumonias. Sometimes pneumonias looks like an interstitial infiltrate. It can happen with viruses and mycoplasma pneumonia. So some more words about when to use CT scan in patients with pneumonia. And the indication says that when there is severe or complex pneumonia, patient with pneumonia who are immunocompromised, and when we are giving the patient antibiotic and he's not responding, or there is a non-resolving pneumonia or a recurrent pneumonia, then these patients need to go for a CT chest. Not to forget, even the patient when we are thinking that this is clinical pneumonia, but chest X-ray is not helping, in all those cases also we can do. And important, but last but not the least, that post-obstructive pneumonia is caused by tumor or foreign body, which looks like pneumonia, but once we do the CT scan, we come across that it was a foreign body or tumor which was giving a mimic of pneumonia. In all these cases, a CT scan should be indicated. So as I mentioned that ultrasound can be a modality of diagnosing pneumonia. So this has come with the ATS 2025 guideline, which is actually the update of 2019 guideline for community acquired pneumonia. And what does it say? It says that lung ultrasound is an acceptable diagnostic alternative to chest radiography in medical centers where appropriate clinical expertise exists. This is a conditional recommendation with low quality of evidence, but yes, now we have three modalities: chest X-ray, CT scan, and ultrasound of lung. There are many biomarkers and blood tests we can do in pneumonia, CBC, TSC. I'm not in the matter of time constraint, I'm going on important and more disputed and discussed topic on biomarkers, which is about CRP and serum procalcitonin. So the guideline says that there is no systematic use of CRP or serum procalcitonin for diagnosis or initiation of antibiotic in both hospitalized or non-hospitalized patient with CAB. But that doesn't mean that serum procalcitonin is not a useful marker. There are many studies and literature which says for patient whom we want to de-escalate the antibiotics, serum precalcitonin can be very helpful. So another important and discussed that question was that should Legionella and pneumococcal urinary antigen testing be performed at the time of diagnosis? As I mentioned, the pneumococcal infection or Streptococcus pneumoniae is the most common cause. So are we going to do the urinary antigen test for all of our patients? So the answer is not routinely, not in OPD CAP patients, not even in the IPD patient who are not severe CAP, even they are hospitalized, we will be not doing pneumococcal urinary antigen test. Then in which condition should we use? We should use this for severe hospitalized patients. Also, if we are suspecting there is a Legionella outbreak or the patient has a recent travel history. And this is as per the ATS 2019 guideline. Another important topic is should gram stain and culture of lung respiratory secretion be obtained at the time of diagnosis? The answer is not routinely, not in OPD patients, not in OPD CAP, but yes, if the patient is admitted, have severe CAP, is being empirically treated for MRSA or Pseudomonas, or was previously infected with MRSA or Pseudomonas, or this patient was hospitalized and received parenteral antibiotic in the last 90 days, we should send sputum for gram stain and culture and sensitivity. The another question is that should blood culture be obtained at the time of diagnosis? And the answer is same as we was there for the sputum examination. The indications are the same. So another important thing is that should we test all our patients with influenza virus RT-PCR at the time of diagnosis? Again, not routinely indicated. When there is an influenza virus circulating in community, we can test for it. And if we want to test, the molecular assay is preferred over the antigen test. So when we are talking about molecular tests, we have many tests in the market: PCR, RT-PCR, respiratory biofire, pneumonia panels. So when should we use these tests? So these are not indicated in OPD patients with CAP. It can be used in non-severe hospitalized patient when there is an epidemic going on, as it is an influenza epidemic or SARS-CoV epidemic or respiratory syncytial virus epidemics. So in all these cases, we can use to establish our diagnosis. We can also use viral PCR in severe hospitalized CAP patient, but we can use the biofire, which are more extensive coverage of bacteria and atypical bacteria and viruses. We can use them as a second line if viral PCR is negative, and when we are suspecting that Mycoplasma pneumoniae or Legionella pneumoniae is my suspicion, and the cases are severely hospitalized CAP patients where we are struggling with the exact etiological cause, and there is not very significant improvement with the empirical antibiotic. In all those cases, one should go for the respiratory biofire or pneumonia panel. So once we diagnose these cases, we come with the next step about how severe are this patient. Should we admit them or should we send them to the ICU? These are the questions which comes to our mind. So severity assessment, first thing is to do is that look for your patient. Is this your patient is fitting in any of this criteria? Is the patient having septic shock requiring vasopressor support, or patient is having respiratory failure requiring mechanical ventilation? If any of the questions says yes, admit this patient and admit him directly to the ICU. If those questions are not been ticked, still patient can be admitted in ICU if they are fitting in the criteria of severe CAP, which are minor criteria: respiratory rate of more than 30 breaths per minute, PaO2 FiO2 ratio of less than 250, multilobar infiltrate. If patient is confused, uremia is there, leukopenia or thrombocytopenia is present, patient went in hypothermia, or there is a hypotension. If any of the three or more criteria is present with your patient, this patient is a case of severe CAP and need to be admitted in ICU. So let's understand more in detail. So if your patient has no septic shock, does not require ventilatory support, look for the second thing, which is the saturation. If the SpO2 is less than 92% on room air, this patient require admission. And then we need to see severe CAP checklist. And if patient fit in the severe CAP, three or more criteria, as I mentioned in the previous slide, is present, then patient should be kept in ICU. But if the patient again has not in septic shock, has no ventilatory support requirement, and the oxygen is also good this time, which is actually more than 92% of the room air, then in all these cases, we apply a scoring system. And we have two scoring systems presently more popular and utilized. One is the pneumonia severity index, which is quite complex, but is preferred one. And the other one is the curve 65, which is easier. So on my left side, this is the pneumonia severity index. Again, looks very complicated. One can use online available calculators for calculating this. And the other, which looks quite easy, is the curve 65, which is confusion. U stand for uremia, which is more than 20 milligram per dl of blood urea nitrogen, respiratory rate of more than 30, BP, systolic blood pressure of less than 90, and if the patient's age is 65 or more. So how we are applying curve 65 in our decision of should we admit it or should we keep it the patient in the ICU. The curve 65 score says that if the score is 0 or 1 here means that the age is 65, then if that only the criteria for 1 is met, then this patient can be managed at OPD basis. But if the score is 1 or 2, patient need to be get admitted in the ward. But if the score is 3 to 5, one should again see this patient if this is a severe CAP or it is non-severe CAP. If it is a severe CAP, admit in the ICU. If it is a non-severe CAP, patient can be kept in the ward for management. So after deciding the site of admission or keeping the patient at home, we come to the treatment part. So what medication should be given to these patients? Let's go back to the ATS 2019 guideline where it clearly defines the outpatient treatment plan for community-acquired pneumonia. And they say just see if your patient does not have any comorbidities or risk factor for MRSA or Pseudomonas, you can give your patient amoxicillin or doxycycline or macrolide. Or if your patient have comorbidity, then better to go a combination therapy, which is amoxiclav or cephalosporin and a macrolide or a doxycycline. It is guided also suggests in these patients to continue a monotherapy with respiratory fluoroquinolones. I would like to emphasize that Indian guideline on pneumonia does not support using of fluoroquinolones because the high incidence of MDR pulmonary tuberculosis in our country. So what if the patient is hospitalized and it's not severe? Then we need to give patient with beta-lactam antibiotics plus macrolide or beta-lactam antibiotic with doxycycline. What if the patient is hospitalized and it is has severe CAP? In all those cases, we need to give again beta-lactam antibiotic and macrolide. But we need to again think about the situation. Is this patients are a known colonizer for or have the prior infection with MRSA or Pseudomonas. If the patient has the prior hospitalization history or IV antibiotic use, or we are suspecting that patient may have a MRSA infection, one need to cover the patient with anti-MRSA activity antibiotic, which is vancomycin and linezolid with the above mentioned regimes. And if we are thinking that this patient may have a Pseudomonas infection because his prior report was showing Pseudomonas infection, he is a colonizer for the Pseudomonas, has a structural lung disease, then we need to cover this patient with anti-pseudomonal beta-lactam antibiotic, which are piperacillin, tazobactam, ceftazidime, meropenem, or imipenem. Let's see, what about the viral pneumonia, viral CAP patient? Do we need to give antibiotic? And the guideline ATS 2025 has come with the update on this topic. They say if your patient is outpatient without any comorbidity and has been tested positive for only viral infection, you don't need to give antibiotic. But if your patient is outpatient with comorbidity or an IPD patient who are severe CAP or non-severe CAP, although they have been positive for just for the viral test, but in all these cases also you need to cover the patient with antibiotics along with the antiviral treatment. And this is a conditional, very low quality recommendation. But yes, that is an important point brought by the ATS 2025 guideline. So once deciding about the antibiotic, we have started antibiotic in our patient and we wonder and we see in our practice that somebody writes antibiotic for 5 days, 7 days, 14 days, 10 days. So let's see what the guidelines say. The guidelines say, once you are deciding for duration of treatment, you need to see the patients about the stabilization criteria, which is that like her fever has got down, blood pressure has got normalized, heart rate is less than 100, respiratory rate has come to less than 25, and saturation is more than 90% at room air, and PaO2 is more than 60 mm of mercury. Then in all these cases, we have to think of de-escalating antibiotic. And if the patient is CAP with non-severe pneumonia and you get the stabilization criteria met in 3 days, one can stop the antibiotic in 3 days. If this criteria met in 3 to 5 days, then antibiotic can be given for 5 days. Other non-complicated cases, it can be continued for 7 days. But there are the cases we know pneumonia which can be complicated, can develop empyema, can develop lung abscess. In those cases, a prolonged antibiotic course is recommended by the guideline. So after antibiotic, the another important topic which was also addressed in latest update of ATS 25 about steroid. Steroids should be given in community acquired pneumonia or not. So the recommendation comes as a strong recommendation. All experts, 16 by 16 fevers, that inpatient CAP patient who are not severe do not give systemic corticosteroid, but inpatient with severe CAP who in whom we can exclude influenza virus and who are not on any immunosuppression per se and who are not aspiration pneumonia, there is a conditional recommendation of giving systematic corticosteroid, and 15 out of the 16 experts favor the use of systematic corticosteroid in severe CAP. And we all know that since long, all the guidelines, whether it is ATS, ERS, IDSA, or survival sepsis guideline, it recommends use of steroids in septic shock patient due to CAP. So, after covering this important points about the treatment, let's come back to our case, which was a female with 50-year with sinus symptoms of cough, fever, and shortness of breath and throat pain. So this patient was a case of pneumonia because in a 2-day timeline, she developed severe shortness of breath, hypoxemia, and a CT scan was done for her, which showed a patchy consolidation in both the lungs. So this patient was a pneumonia. Just to conclude on our case, and with this, I thank you all for your patience listening. And now I would like to invite Dr. Arnab Bera for his talk on HAP and VAP. Thank you very much.
Congratulations, Dr. Ambika, on your nice presentation. And thank you, Dr. Komal, the CCI team, Ravi sir, Atri, for again inviting me for this nice discussion. Today we are going to I'm going to talk about the management of hospital acquired pneumonia and ventilator associated pneumonia. Myself, Dr. Arnab Bera, I'm consultant in respiratory medicine and critical care in Manipal Hospital, Kolkata. So first, I'll start with a case. So this is a 75-year-old male who is a known COPD on home nebulization therapy, hypertensive on medication but controlled, non-diabetic. So he basically admitted with fever for 2 days, along with a breathing problem actually worsened, and cough, a little bit of expectoration. So on the day of admission, he had a diffuse bilateral bronchi and room air saturation was 85%. And you can see the initial first one, the initial X-ray, which is showing a hyperinflated lung fields, but there was no definite consolidation. We started on amoxicillin, clavulanic acid, doxycycline, nebulization, steroid, the standard management along with DBT prophylaxis. We sent the sputum culture, which revealed actually no significant growth. Initially, the patient improved also with medication, but from day 5 of admission, the patient again started to deteriorate rapidly and had to put on mechanical ventilation for worsening respiratory failure and started to require vasopressor support. You can see the X-ray, which was done before the putting the patient into ventilation, which is showing a new onset, consolidation in right lower zone. After putting into ventilation, we send the ET cultures, but the patient deteriorated rapidly and expired within after next 48 hours from refractory shock. A day later, actually, the microbiologist informed me the huge growth of Acinetobacter, which was sensitive to colistin only. Now, I'll not give you the answer what to be done exactly in this case, so that we can save the patient. Probably that would come from the discussion. But now I'm going into my main presentation. So if you see the ICU respiratory infections are very common in ICU. This is a journal JAMA 2019 study. So if almost more than 50% ICU infections are kind of respiratory, and there are certain bad bugs in the hospitals. So these are Enterococcus, Staph, Klebsiella, Capsaicin oxa, Acinetobacter MDR, Pseudomonas, and definitely ESBL and CRE. Okay, so these are called basically escape organisms. And I would ask everybody rather, what is the resistant burn in your experience in your ICU? For my ICU, probably it is CRE followed by Acinetobacter pneumoniae. Okay. So if we see the overall evaluation of gram-negative pathogens with the drug resistance, so initially that was a susceptible gram-negative pathogen, but after 1960s when we introduced ampicillin, so we get some resistant E. coli. Followed by 1980s, we started cephalosporin like ceftazidime, cefotaxime, and we started to get resistance E. coli, Pseudomonas, and Klebsiella with this MC and BLA kind of beta-lactamases. Okay, and in 1990s when we started carbapenems, now we are getting resistant E. coli, Pseudomonas, Klebsiella, and Enterobacter species with this NDM, VIM, CTX, and porine defects and metallo-beta-lactamases kind of resistance. So overall, if you see the epidemiology in India, so the incidence of VAP, in India ranges from almost 30 to 73%. Early VAP ranges from, kind of 40 to 50, 45%, and late 55 to 60%. So late VAP means which is developed actually 5 days later after the late mechanical ventilation. And the gram-negative organisms are very much common in both early and late VAP. So Pseudomonas, E. coli, Acinetobacter, these are the common organisms. And most of these Enterobacter are ESBL producer or carbapenem resistance is also high. So you can see up to 40% of Pseudomonas, 37% of Acinetobacter species are MDR even to carbapenems. So why this kind of increased carbapenem resistance strain? So basically with the increased carbapenem use, there is selection of carbapenem resistance genes, and these genes are actually getting transmitted, and the spread of resistance genes happens, which are actually producing this carbapenem resistant Pseudomonas, Acinetobacter, and Enterobacter. And these you can see the proportion of carbapenem resistant Klebsiella pneumoniae. Among that, if you see almost more than around 60% Klebsiella are carbapenem or cephalosporin resistance, and almost 15% are polymyxin B resistance. And if you see this carbapenem trends over years, so the oxa endemicity in India, so there is, you can see the oxa 48 resistance is seen in 20% or along with 50% for NDM. Why this resistant pattern is important? Because if the patient has kind of only oxa 48 resistance, so you can give ceftazidime avibactam kind of combination. But if there is NDM, so you have to combine this ceftazidime avibactam along with astronam. And if it is Acinetobacter, then you have to go to polymyxin B or minocycline like combinations. So now, how will you diagnose this nosocomial pneumonia? So basically, when a patient who is hospitalized and on mechanical ventilation more than 48 hours and developing a new or progressive infiltrates on chest radiography, along with at least 2 of these following, that high-grade fever, leukocytosis, leukopenia, altered mental status, new onset purulent sputum or change sputum character, worsening gas exchange, new onset or worsening cough or dyspnea, or there is rail or bronchial breathing, then you have to suspect. And why this is crucial? Because this is the most crucial task is VAP is to arrive at an early diagnosis. Because often it is difficult because many conditions common in ICU like sepsis, ARDS, pulmonary atelectasis, which can may present like a similar kind of picture. But if you want to diagnose this VAP, which is actually based on these 3 important components, where you get a systemic sign of infection, new or worsening infiltrates on chest X-ray, and you get an bacteriological evidence of pulmonary infection. So hospital-acquired pneumonia, what are to do with the sample? You can take a respiratory sample by spontaneous expectoration, sputum induction, or nasotracheal suction. You can subject that to semi-quantitative culture as per ICMR guideline. In cases of VAP, the preferred method would be, blind or targeted, bronchoscopic or non-bronchoscopic, respiratory sample, depending on center expertise. But blind, endotracheal aspirate is the easiest and which is associated with similar kind of, outcomes when you take a targeted bronchoscopic secretion also. In intubated patient, suspected VAP, should distal, quantitative samples should be obtained. These are years. So previous one is the ICMR. Now these are years. So there is no mortality benefit, but you can focus or you can narrow the initial empiric antibiotic regimen once you get a lower respiratory sample. Okay. Biomarkers. So procalcitonin. But as per this IDSA guideline, they are recommending clinical criteria alone rather than using procalcitonin or clinical criteria for initiating this is important for initiating antibiotic therapy, not for stopping. This is for initiating, even not a CPI score, not a CRP. So clinical criteria only they are giving emphasis on. So management. how do you what the guideline actually is saying. So as per this ICMR 2019, so empirical antibiotic therapy should be initiated in case of VAP and HAP based on the clinical criteria after you have to send the respiratory and blood culture samples. And best guide for antibiotic therapy for empirical regimen is the data on local microbiological food and resistance profile. So the preferred one would be if there is a culture to VAP and HAP, and most commonly they are Acinetobacter, clave, or pseudo. So you have to take either piperacin tazobactam or ceftazidime sulbactam or imipenem celestine or meropenem or colistin or polyp. And if there is a MRSA, so you have to choose either linezolid or vancomycin or teicoplanin. But colistin and polivexin should be used only when the there is resistance to all other tested antibiotics. And for HAP and VAP, due to CRE who remains in septic shock and at high risk of poor outcome, then you have to use combination therapy of two antibiotics, which is susceptible rather than monotherapy. Okay. So what they also say, in susceptible cases, levofloxacin you can use as an oral step down therapy. Ferropenam should not be used as a step down therapy. Tigecycline is usually not recommended in VAP. In patient with suspected VAP with a septic shock, rapidly deteriorating status, empirical coverage for MRSA and carbamazepine GNB, you have to add along with anti-pseudomonal beta-lactam you have to add, and de-escalation should be done once the culture report is available. Recommended duration usually 7 days, but in case of immunodeficiency, empyema, lung abscess, necrotizing pneumonia, you can increase this. Clinical picture and procalcitonin level may be used to discontinuation of antibiotics. So if you fill the criteria, we will send the sputum sample and cultures, and you reassess in every 72 hours. And if the criteria is not fulfilled, probably pneumonia is unlikely. Fluoroquinolone should be only used when there is a contraindication to aminoglycoside, because it's a kind of reserve drug for tuberculosis. Okay, and MRSA coverage to be given if there is almost 10 to 20% documented high prevalence of MRSA. So if the patient is not at high risk of mortality or likelihood of MRSA, we have already given the combination pipzo, cefepime, or levofloxacin or meropenem. And if there is likelihood MRSA, you can add vancomycin. And if there is a high risk of mortality, then you have to choose dual antibiotic therapy. Okay. So these are the recommended guidelines. Usually for Pseudomonas aeruginosa against aminoglycoside monotherapy. So you have to give definitive therapy based on the results. And Acinetobacter, definitely if there is only sensitive to polymyxin, if the species only sensitive to polymyxin, then you have to good polymyxin. See that the different doses. I'm not going to details of the doses. Inhaled antibiotic therapy, definitely if the patient is having VAP due to gram-negative bacilli, so you can start both inhaled and systemic antibiotic therapy, but an aerosolized antibiotic should not be used as a monotherapy. Okay. So if the patient is a ERS guideline again, HAP VAP, assess the risk of MDR pathogen. If there is a low MDR risk pathogen, you can start monotherapy. If there is a high risk MDR pathogen and risk of mortality, if there is no septic shock, you can again add a single gram-negative and plus minus MRSA therapy. But definitely if the patient is septic shock, you have to give dual gram pseudomonal coverage plus minus MRSA. Okay. So delayed appropriate antibiotic therapy in gram-negative infection has been associated always poor outcomes, like 80% increased length of hospital stay, 30% decrease of being discharged, 70% increased duration of antibiotic therapy, and there is 20% increase the risk of in-hospital mortality. And how you prevent the VAP? So basically head and elevation, this is a VAP bundle, oral care with chlorhexidine, stress ulcer prophylaxis, daily sedation assessment and spontaneous bleeding trial, and deep venous thrombosis prophylaxis. So thank you. We are surrounded by bugs in the hospital. Thank you. Thank you.
Thank you, Dr. Arnab, sir. That was an excellent talk. I would also like to thank Dr. Ambika for the insightful talk. And let us start the panel discussion from here on. So, Ambika, I would like to take your case only for the further discussion. So, So here is a case of 52-year-old male. He's a known case of diabetes, and he presents to us with same short history, 3 days history of fever, cough, breathlessness. Now the patient on examination is febrile. He has respiratory rate of around 26 per minute. BP is stable and saturation is around 92% on room air. Investigations show high leukocyte counts and otherwise normal urea and create. Now his X-ray is showing right lower lobe consultation. So I'll come to Dr. Ambika first because it's her case. So Dr. Ambika, how would you assess this patient at the first go? Are you using any scoring system, any criteria? You have explained very nicely in your presentation, but we would like to know practically that there are scoring systems. But do you apply this to the same patient? And on those basis, are you going to treat him on outpatient basis or in ICU or where? So tell us about that.
It's a very important question. That's why in the presentation, many of the theory part I didn't cover, and I put this part because practical in how we are managing this patient. So if I come across a patient like this, my first step is usually seeing the patient in the bedside clinical assessment and looking for any life-threatening instability in the patient. If you see the patient, you find the patient is in apparent respiratory distress, the oxygen is low and BP is low, patient is in altered mental status, then I know this patient need an admission and I don't need to apply any scoring system at that very moment, and probably I will be admitting this serious patients in ICU. But yes, then when there is no hypotension, respiratory failure is not there, but there are the signs and symptoms and the radiological presentation of pneumonia, then we think of that should we keep this patient in ward or at home, and sometimes then we use the curve 65 score or the pneumonia severity score. These are the two scores which are quite discussed in literature, where the curve 65 is basically mentioned in the BTS guideline and the PSI score is mentioned in the ATS guideline. I find the pneumonia severity index is quite complex, although one can use the online available calculator to calculate these cases. But if you ask me academically, I use curve 65 score, and when the score is really low, like 0, then this patient need to be kept on the OPD basic treatment. But yes, if the score is more than 3, then we think of admitting this patient, but we definitely need to apply the severe CAP scoring system here. Like other parameters need to be seen, that patient need to be kept in ward or ICU or somewhere else. So yes, if we see in this particular case, you see, if I apply the curve 65 score, it will go 0 because the patient's age is so not fitting. There's no confusion. The urea is normal. The respiratory rate all a little high, but not as high as what we need for the scoring. And the BP is also, so it becomes a 0 score. But if you ask me in clinical practice, this patient is a saturation of 92% with no any underlying lung disease, which is kind of little low for his age and for his disease. And this patient also have a diabetes. So keeping that two things in mind, I will probably ask this patient for a short hospital observation. And here comes the fallacies, or maybe the curve scoring, which does not even include the oxygenation part in the scoring system. But when we see patient in clinical practice, we definitely think that oxygen is a very important. During COVID time also, the absolute criteria was that if the saturation levels are less than 88, just get the admission immediately. So I think the scoring system can complement us, like they can help us, but definite thing will be that we do our clinical judgment first, and then we can use as a complement as a severity score, curve 65 or PSI, whatever you want to, not to forget to do the oxygen assessment. And the patients who have the comorbidities, they need to be taken care, especially. And I here want to emphasize, whatever the scores we are talking today, they were not made for the immunocompromised patient. They were all for the immunocompetent patient. So this immunocompromised group will have a very different course of pneumonia. So we need to take care about this also when we are applying such kind of scores. Not to forget, even in the Indian context, that social factors like home support, will the patient will be able to take oral drugs. I sit in a medical college where the patient come from the far from the villages, and if I keep a borderline case and ask them to come after a few days, it will be difficult. And I would rather admit such patients in the hospital for the close follow-up, where the healthcare assessment, reaching to the healthcare can be tricky. So yes, the severity scores are there. They are the helpful tools, but they are just supporting little decision making. They cannot replace our clinical judgment, and yeah, they should be used as a complement only.
Very, very nicely put, Dr. Ambika. So, just to summarize that for COP 65 or PSI score to apply, first we must rule out that whether it is severe pneumonia or not. If it is not there, just look at the saturation. If it is not fitting into that, the saturation is also fine, then only look at the PSI and COP 65 score. Unless the patient is immunocompromised, lot of comorbidities, don't apply that, or apply it with some clinical acumen with that. Also, I would like to mention that in some literatures, they've mentioned that COP 65 actually underestimates the pneumonia severity, and PSI actually overestimates it sometimes. So we have to just take our own judgment rather than just blindly following this course. Very nicely put, Ambika. So next question is for Dr. Madhukar. So, sir, now we have decided to admit this patient, as Dr. Ambika said. We are following her instincts. So we are admitting this patient. So now, are you going to straight away start the antibiotics on him, or would you like to wait? So what does the guideline say, and what is your clinical practice actually? Do you just immediately start on antibiotics, or what is your routine practice? Sir, you are on mute.
Yeah, thank you, Dr. Komal, for asking this. I mean, this patient is a classic example where we see a clear dissociation between, the kind of outcome we are seeing for this patient and the severity score that we commonly use. Now, this patient has been admitted by Dr. Ambika to a hospital. So now I believe that I wouldn't wait even for a second to start the antibiotic in this case. Forget about the patient of CAP who is getting admitted. Even a patient of CAP who is being treated outpatient should be given the first dose of antibiotic within 4 hours. And if a patient is getting admitted, he should get a first dose of antibiotic within the first hour. But telling this, since this patient is admitted now, before starting the antibiotic, I'll send a sample to the microbiology lab, and then we'll start give the first sample. Why I'm telling all these things, because CAP still remains a significant cause of mortality globally. And the commonest organism of CAP that we discussed, Streptococcus pneumoniae, is also the commonest etiological agent associated with the highest mortality in the CAP. And we also have the evidence that even if you give a pathogen-directed treatment rather than giving an empirical treatment, it doesn't make any change in the outcome. So I'm very clear about it. I'll immediately give the antibiotic to these kind of patients, to every patient with the CAP.
Yeah. Thank you, sir, for the insight. And I hope everybody is agreeing to this, or is there any other view? Because there are there are some dilemmas in the treatment. For example, like into this 4-hour rule came from the study which was published in NEJM in 2004, where they mentioned that giving antibiotic in 4 hours, within 4 hours, it actually reduced the mortality. But afterwards, in 2008, Welker et al., they published another data where they mentioned that when they were planning to give antibiotics as soon as possible, in that time they started overdiagnosing pneumonias. So those patients with pulmonary edema, those patients with chronic exacerbation of COPD, they also started getting antibiotics because we wanted to reach that 4-hour timeline. And because of that, the another group of thought is that first you confirm your diagnosis. If you are really sure that this is pneumonia, start antibiotics. But if you are not sure, go ahead with the test to make yourself comfortable that this is pneumonia, and then you start antibiotics. Now, there are exceptions to this thing, that is if the patient is in septic shock. The surviving sepsis guidelines mention that if the patient is in septic shock, you have to give antibiotics within 1 hour. Or the patient is having severe CAP, or the patient is having meningitis, in those cases, definitely we would give antibiotics at front, without thinking of any other investigation. But if the patient is stable and you are not sure if this is not CAP, then you can just wait till your diagnosis is confirmed. I hope,
Yeah,
yeah.
Dr. Kamal, I'll just see to the flipper side of this, the NECM article, then the Cottons articles, all you discussed very well about it. But then we have a problem, like the case that Ambika was discussing. The patient who had all the clinical symptoms suggestive of pneumonia, the clinical findings, X-ray was normal. Remember, your patient is diabetic.
Yes.
He is a comorbid patient with lesser saturation. So even if the patient doesn't have a lesser saturation for a minute, the patient is diabetic, the X-ray is normal. You are not sure that this is pneumonia. You would like to investigate the patient further. But if
Yes.
you are going to delay the treatment with antibiotic in a comorbid patient, you're definitely asking the risk to
Correct.
come. So
Yes.
let's be very,
I would suggest let us start the antibiotic, then you work up. If
yeah,
that
of
is
course.
not pneumonia, if you're sure that is a heart failure or kind of thing, then there is always a chance you de-escalate
Yeah,
the
You
antibiotic.
this is,
de-escalate. Yes,
yeah,
yes. That is also one way of looking at it, that we can start with the antibiotics, and as soon as we feel that this is not pneumonia, we can quickly de-escalate or stop the antibiotic. Yes, that is also one way of looking at it. And thank you very much for the answer. Dr. Utkarsh, I want to know that this patient, now, sir, thinks that we should start antibiotic. Ambika says that we need to admit the patient. So now, after that, we have one X-ray with us which is showing right lower lobe consolidation. So, is that enough for us, or you would want to go for CT scan? Or nowadays, POCUS is also in a limelight. Everybody is about POCUS. So, you want to do USG in him or CT scan, or you're happy with X-ray?
So thank you, Dr. Komal. So firstly, it's a right lower zone consolidation that we can see on the X-ray. Patient is an uncomplicated pneumonia patient. If we take about the 65, we are currently hemodynamically stable. So I would not go for CT scan straight away. What I would keep it in reserve. Look for clinical radiological response in clinical response in next 2 to 3 days. And in case of any suspicion of necrotizing pneumonia, any other complication, abscess formation, any empyema formation, then or to rule out any other cause of any malignancy if it is a suspect, or embolism if it is a suspect, then only I would go for a CT scan straight away. Otherwise, I would keep it in reserve, look for clinical response. If I am achieving a clinical response, I would prevent unnecessary exposure of radiations. And talking about lung ultrasound focus, yes, it is in talks. And currently, if I say any private ICU, a good running private hospital ICU, have an ultrasound machine with them. And so it is very handy to do a focus at any time the patient is admitted, patient is on ventilator, patient is bedridden, cannot move it for CT scan, or kidney injury is also very uh, common in patients with pneumonia. We can't go for a contrast, so we can go for a easy, radiation-free, repeatable thing that can be performed bedside. So focus should be done if it is available. And I think it has a good high sensitivity,
Yeah.
specificity. We can look for B lines. We can look for any on
Air
findings like
bronchograms also.
consolidations, yeah,
Yeah.
air bronchograms. So it's a good investigation when we can reserve a CT scan and go for an ultrasound and look for any other findings. We can also rule out if there is any associated effusion along with the pneumonitis.
Correct. So basically, more useful when the consolidation is subpleural or peripheral, then it is very
Right.
much useful, and we have been using it. So I think nowadays almost all of us use focus for our patients whom we are not taking for CT scans. Thank you, Dr. Utkarsh. And now I'll move to Dr. Abhishek. Sir, in this patient whom we are treating as suspected CAP, the ATS guidelines in 2019, as Dr. Ambika mentioned in her presentation also, they are mentioning that we do not need to send routine sputums for routine microscopy and cultures if the patient is having mild CAP. Now, this patient fits into that category. So do you agree to that, or you will anyhow send the sputum microscopy and culture? What is your routine practice at your center? Sir, you are on mute.
Ma'am, thank you for the topic. Ma'am, as the guidelines is banned by ATS and ERS, in that
Yeah.
countries, the antibiotic over the counter use is very less.
Hmm.
And the drug resistance compared to India is very less. So we should always see in our context what we are dealing. Again, in this case, you see the patient is diabetic. He's not a immunocompetent. He's a immunocompromised if you take diabetes in our country. So I invariably send every patient for the sputum test before starting antibiotics in our context, as the prevalence of MDR organism is quite high, and it also helps in see the what is the baseline patient's status of the resistant pattern, so that it can help us in narrowing the antibiotic if the patient deteriorates.
Yes.
So I will definitely send for sputum testing in this case, before starting the antibiotic.
Okay,
And
and do you stand only for routine smear and culture, or you have the any other microbiological test you do for this, like TB? Do you send for CB-net or?
ma'am, it will depend, ma'am, on the patient's clinical picture also, ma'am. In every
Hmm.
case, we don't send CB-net. If the patient, I'm suspecting that the patient is diabetic, having the picture of X-ray or in radiological picture showing of TB also, I will definitely used to send for Gene Expert or CB-net. Then multiplex PCR also sometimes in private settings we used to send. The patient is having deteriorating fast. Again, in our setting in Northeast, scrub typhus is quite common nowadays, and patients are coming with pneumonia. Then later on they turn out to be scrub typhus positive. So
Correct.
we are routinely nowadays setting for scrub typhus also.
Also, right.
And if the season is outbreak of viral outbreak is there, in this season, a lot of viral cases we are getting. We think of influenza also. If we are the bacterial like blood counts are normal, procol is normal, then we think of about viral picture also, ma'am.
Correct, correct. So absolutely right. Why I was asking for CB-net, then nowadays residents have habit of writing routine smear, routine culture, AFB smear, CB-net in all the patients. So I don't think that CB-net is to be sent in all the patients. We must see the duration of symptoms, whether patient is having any comorbidities or it is just simple pure cap. But of course, we are the endemic countries, but then we have to be careful in that thing also. So the next question for Dr. Arnab Bera, sir. Sir, in this patient, what other test can we do? Like the guidelines suggest so many tests, as already mentioned. So if it is moderate or severe pneumonia, they are suggesting n number of tests. Is it everything is possible in our routine setup, or we are happy with just routine CBC, RFT, LFT, and sputum cultures, or do you send any practically? Do you send any other test for this kind of simple pneumonias, the patient that we are seeing right now?
Yes, for simple pneumonia, definitely, Komal. Basically, we can send this what you have said already, that we can send the routine renal liver function just to be sure that there is no other organ impacted. Okay, so that patient should be kept in a ward. Okay, and if CT scan, definitely what already you have already said, mentioned, that is not routinely required. Definitely, if the patient is in ICU or HDU, apart from, so it all depends on which setting you are working on. Okay, so in basically you need a ABG definitely to see the lactates kind of thing. You can send a procal initially, not to start antibiotic, but rather to you can see rather to de-escalate antibiotic. The trend is important, so you can send CRPs and procalcitonin kind of thing to see the trends. Yeah, and if the patient is in ward, definitely I'm happy with sending a sputum culture. Preferably, if affordable, I can send a blood culture too. But definitely, if the patient is being shifted to HDU and ICU, depending on setup, rather in our hospital, what I am completely agree with Dr. Abhishek, that in our country, the drug resistance is kind of a community. This is a community thing where we get a drug resistant pattern of kind of thing. So if the patient is in HDU and ICU in our setup, like I'm working in a corporate tertiary care hospital, I always, if the patient is if relatives are affordable, patient is affordable, I sometimes do a bronchoscopic bell and send the PCR techniques on the day one. Because once the patient is in 2-3 days in hospital and ICU, so there are other commensals which you get in the PCR methods. Okay, so in rapid, day 1 or day 2, if you send, you will get an idea the what bacteria is there, and you can give your antibiotics accordingly, so that there is a lesser chance of deterioration. But it's all depend on which setting you are working on. Otherwise, these basic tests would suffice, definitely.
And what about antigen tests, urine antigen
Yes,
test
yes,
for
yes.
pneumococcal
Because
Legionella?
Streptococcus is sometimes difficult, even Legionella is difficult to grow in culture. If there is a definite consolidation lobar pattern you are getting, and the patient and you are getting the patient in the ward, you can state a streptococcal urinary antigen. Even I routinely also say that the patient is stable. But if I planning to send cultures from the lower respiratory sample or sputum, then and PCR, then usually we don't send. Otherwise, we can send the urinary antigens even in resource limited setting also.
Right. And what about viral PCR, sir? Do
It all depend on the endemicity. Yes. So if there is a flu outbreak going on, the SARS-CoV. See, I don't send all kind of all viral panels, because it doesn't help in like you don't get treat this virus, all the virus. Okay. So SARS-CoV and influenza. Okay, these two things. When there is an outbreak, you can send these two things. Other viral, usually we don't routinely send.
So we can just say that if the patient is not affording and minimal investigations we have to send, we'll send routine smear and culture and the basic ones. But then if we have the chance to send, then we'll be sending more like viral PCRs, blood cultures, and also antigens if required. For Legionella, if there is outbreak, if the patient has travel history, if there is hyponatremia or patient is deteriorating fast, maybe we can send that also.
Even in see, if you have to get focused, if the patient has a structural lung disease underlying, so you have to definitely think of Pseudomonas. If it is a post-influenza pneumonia, you have to think of staph. If the patient is immunocompromised, you have to think of fungal or TB. So these kind of things you have to also kept in mind.
And then it varies from patient to patient, and of course the resource whatever we are having. So coming back to Dr. Ambika, in your presentation, you very nicely mentioned that which organisms are traditionally there causing community-acquired pneumonia. So can you please again tell us so that we revise it? And do you think that the pattern is still the same in our country, or it has changed? Or in your day-to-day practice, what are you seeing? Are you still seeing streptococcal pneumonia as the most common cause of pneumonia?
So, Komal, again, I want to emphasize that whatever the literature, what we are seeing today, whether it is coming from India or from the worldwide, Streptococcus pneumoniae is the most common etiological agent for community-acquired pneumonia. Although there is a trend of decreasing the incidence and prevalence of Streptococcus pneumoniae, and other bacteria and viruses are also picking up. But yes, if you ask me, the most common, it is Streptococcus pneumoniae, but we quite often see the H influenza infection with the Staph aureus infection, Klebsiella, and Moraxella catarrhalis, also especially in patients with COPD. And not to forget, whenever we do biofire, and we come across that Mycoplasma pneumoniae is also not uncommon in even in Indian practice to see. Chlamydia, we do not see that frequently, but Legionella is only seen when we are thinking about some kind of outbreak or the patient has exposure of some kind of water body, then only we get to see. Yeah, but Mycoplasma among atypical is quite common. Coming to the respiratory viruses, yes, influenza virus, we know in every season there is the peak of influenza virus. There is mutations also. Respiratory syncytial virus is also common. We came across last winters about human metapneumovirus, and in my practice also I saw in some cases only we do the biofires. We are not doing in all cases. So there also we saw that there were the few cases of human metapneumovirus. And not to forget that during COVID time there was only one incidence of pneumonia, which was coronavirus, and then that time we were not finding even Klebsiella, H influenza or Streptococcus pneumoniae. So these are the trends which has been changing whenever there comes the epidemic or pandemic or the season is there. We, after the COVID, has now been picking up more viruses, more mutations in viruses, possibly because of use of biofires and pneumonia panels. So this is giving a little shift in the finding more viruses. And because we are doing the biofires, we are picking both bacterial and virus, which we were not able to diagnose from the sputum culture reports. So mixed infections are also becoming common. And in Indian community, I would say what the sir was, Arnab sir was also emphasizing, even in the community, we are finding the patients are coming with the Klebsiella pneumoniae. Even they can have a Pseudomonas aeruginosa if they have a structural lung disease or they have the repeated healthcare exposures. So these are the some shift. And one another important thing I came across about the, we have this practice of pneumonia vaccination among children and adults also. And what we have been noticing that um, patients who have been immunized with some particular type of pneumonia vaccine, whether it is PCV 13 or PPV 23. So it covers 13 of that serotypes or strains, but the remaining strains are not been covered, and the patients when come, they are being infected with Streptococcus pneumoniae with the different kind of strains. Yeah, so this is kind of some trends and shifts are there, but yeah, Streptococcus pneumoniae still stays the most common cause.
Yes, very well put. And one more thing I wanted to ask in this shift of trend, with that, I wanted to know that do you find patients of tuberculosis or fungal pneumonia presenting as CAP? I'm asking because we do have some patients who have presented as community acquired pneumonia, turned out to be fungal or tubercular, they came positive. And there are studies also, I guess the study was published by AIMS only, that there 20% patients were tuberculosis after they got to know later that the patients were having tuberculosis were treated as community acquired pneumonia initially.
Very important point brought by you, and this was not even covered by me in my lecture also. So yes, fungal pneumonias are common, especially in immunocompromised patients with malignancy who are on immunosuppression. Diabetic patients also, we quite often find to Aspergillus fumigatus infection. Even mucor is not uncommon. They have some typical presentation on CT scan, and when we know that there's a background of this kind of immunosuppression and this patient is not responding in 24 to 48 hours, we should keep the high suspicion of even the fungal pneumonia and unusual pathogens in these patients. I agree with you. The fungal pneumonias are also can be there at the very first place in some patients.
So recently only we had this very young female who presented with community acquired pneumonia. She was type 1 diabetic, and we did BAL. She had already received antibiotics outside, and we did BAL, and it turned out to be mucor positive. Like in smear only, the microbiologist called me that KOH mein BAL dikh raha hai. So we started her on M4, but this is now becoming common that patient presenting as CAP but turning out to be fungal or tubercular. Okay, so with that, we move on to Dr. Madhukar, sir. Sir, what are the common risk factors for MRSA, Pseudomonas, and I want to talk about here drug-resistant streptococcal pneumonia. That is very important. So can you please tell me that what are the common risk factors for these things?
Thank you, Dr. Komal. We start suspecting drug-resistant pathogen in any case of pneumonia when the patient has previous isolation of the resistant organism in their respiratory sample. Another common risk factor for the emergence of drug-resistant pathogens are prior exposure to any intravenous antibiotic or prior hospitalization, especially within the last 3 months. Any patients with a structural lung disease, for example, bronchiectasis, for example, emphysema with pre-bronchiectasis, these are the patients we, as a pulmonologist, usually see them. Now, specifically for MRSA, there are certain predisposing risk factors. For example, if the patients are confused, has the history of head trauma, if the patient has gone bronchoscopic procedures in the last 2 to 3 weeks before developing pneumonia, if the patient is in renal failure, or if the patient has diabetes, then these are the specific risk factors for the development of or emergence of MRSA. So under these circumstances, we should suspect drug-resistant organism. Now, if you are specifically asking the MDR Streptococcus pneumoniae, this is a very pertinent question in community-acquired pneumonia, because now most of the isolates of Streptococcus pneumoniae are penicillin resistant. And penicillin resistance is not a much a problem for us, because even if the MIC is, above 2, these patients with penicillin resistance do respond to the beta lactams. The problem is when a Streptococcus pneumoniae are macrolide resistant, and which is
Yes.
really a concern, because a macrolide resistance means treatment failure. So, at this point of time, I would like to give a message to all of us that we should never use macrolide as a single agent in the
Yes.
treatment of community acquired pneumonia. But there is a good news. The news is that all the Streptococcus pneumoniae resistance are serotype specific resistance. So most of the serotypes which are resistant are actually covered by the pneumococcal vaccines. So again, a message I want to put across is, if your patient is at risk of developing pneumonia, whatever the risk is, a chronic smoker, alcohol, diabetes, elderly, renal disease. So whatever the risk is, please give them the pneumococcal vaccine, because that vaccine covers all the serotype which are resistant to both macrolide as well as, the penicillin. Thank you so much.
So excellently put, sir. All the points are very valid that we should not be treating the patients of community acquired pneumonia with single macrolide. We should be immunizing all the patients for streptococcal pneumonia. Very well put. So next question is for Dr. Utkarsh. Now coming back to our case, this patient was admitted with mild cap, and so what empirical antibiotic do you want to start now? We are not going ahead with any other investigations. We have sent the sputums and some maybe viral PCR we have sent. So what are you going to start? What are the empirical antibiotics advised, and what are you going to start in your patient?
So for this patient, basically for any of the patient, antibiotic selection empirical depends upon the resistant pattern in that area, about regarding the comorbidities that patient has, about the possible adverse drug reactions that we may suspect. So there is no first line empirical antibiotic that we can select for all kind of our patient. We have to be very specific about the patient, and as per the patient we have to choose our antibiotic. So coming to this case, it is an uncomplicated, less than 65-year-old patient with no comorbidity other than diabetes. So I would prefer giving an amoxicillin along with a macrolide or a doxycycline for this patient. If the patient, as this patient has no hypersensitive reaction, but if the patient has an hypersensitivity to amoxicillin, so we may use a third generation cephalosporins like cefodoxime for the patient. Had this been a complicated patient with some comorbidities, a smoker more than 65 years of age, or use of antibiotics in the last 3 months, so I would have used amoxicillin plus clavulanic acid along with either of the macrolide or doxycycline. I usually avoid using fluoroquinolone straight away without ruling out tuberculosis. So that is also important, that if we are using fluoroquinolone, we should be clear that there is no active tuberculosis infection in the patient.
Okay. Okay, and what if the patient was MRSA, suspected MRSA or Pseudomonas?
So in case we are suspecting an MRSA or Pseudomonas, so in patients who are Pseudomonas or any of the other gram-negative infections, then anti-Pseudomonal beta-lactam should be used. So I prefer using a piperacillin tazobactam, or we can use meropenem, imipenem, we can use ceftazidime, cefepime with combination of an anti-Pseudomonal fluoroquinolone, basically. For empirical MRSA infection, I would say empirical MRSA should not be given until or unless the patient is in septic shock, the patient has any respiratory failure, there is patient is on mechanical ventilation, where we don't have time. So, and we want to use, so we use vancomycin or linezolid. Looking at the KFT reports, if there is no nephrotoxicity, acute kidney injury involved, we can use vancomycin. We should monitor KFT on daily basis if we are using vancomycin. Other than that, we can use linezolid for MRSA infection in combination with anti-pseudomonal if we are using peptide combination or something.
Excellent. And what about HCAP? So I wanted to mention that also, that previously in guidelines, when we were students, we were studying about HCAP or healthcare associated pneumonias. And that time, the class of drugs were different for that. And now they have merged HCAP with the general cap. So do you think this is okay if the patient is coming from some community health sanatorium or some long-term care facility, you are going to still treat him as cap, or are you going to change your regime?
So this was actually the main reason that HCAP was removed from the guidelines, because we were using higher end antibiotics, and that was causing an overuse of empirical antibiotics without bringing any significant change in the outcome of the patient. So that was the reason why it was removed. So I think it is right that HCAP was removed, and if the patient lies in any of the categories of the uncomplicated, complicated, or with the exposure or something, so we can decide on our antibiotics as per the CAP guidelines, and unnecessary increasing just because the patient is coming from an HCAP with a good immunity, there is no immunocompromised status, there is no comorbidity. So I think empirical CAP guidelines antibiotics are very good.
Right. So absolutely, very well put, that we have to treat those patients like usual cap patients based on severity and comorbidities, rather than patient is coming from some healthcare facility or not. Okay, so now, Dr. Abhishek, we got the reports now, and surprisingly, like I was suspecting streptococcal pneumonia, but now viral PCR has come positive. And we had already started on, we had started on amoxiclav, right, Dr. Utkarsh? We had started on amoxiclav plus macrolide. So what do you do now? We should stop the antibiotic, or what should we do?
If you go by guidelines, if the patient is showing viral PCR positive, and then we should stop. But if you go with a clinical picture, you have to see the clinical picture of the patients, and we know PCR comes within 5 hours, and your culture takes 40 to 32 hours to come. So we have to assess the patient before it's safe to withhold the antibiotic, but we have to see whether the patient is improving clinically or not, whether the patient's high risk patient's clinical other comorbid condition also we have to see. If the patient, we have to, if he is improving, then we can de-escalate the antibiotic. But waiting for the culture report will be the better option always. After that, we can de-escalate the antibiotic if he is improving in 3 to 5 days time. And we have to also see whether the procal serotonin, which is also a strong, highly negative for bacterial, if it is less than 0.25, then we can think of discussing the antibiotic based on that one.
So based on clinical recovery plus culture reports plus procalcitonin, we can decide whether, yes, we can decide whether to continue or stop the antibiotics. Here in 2025 guidelines, as Ambika mentioned, in ATS guidelines, they mentioned that we can still continue with the antibiotics in the patient who are having severe CAP, or who are having sepsis, hospitalized. And there was this difference of opinion between ATS and IDSA as well, and that's why IDSA stopped endorsing the guidelines too. I'm right, is it the correct thing, Dr. Ambika? I think you've gone through it.
That's correct, yes.
Yes. So I think, but we need to take it in a way that we look at procal, we look at clinical condition, and we look at cultures if we have sent, and then we decide whether to stop or continue with the antibiotics, even if the viral PCR has come positive.
And how about the antiviral? So we have clinically two, and then we have to add antiviral also.
Yes,
because now something has come. Where are we going to?
Again, we have to see this one patient, whether the patient has a transplant recipient or neutropenic patient, or any malignancy case, past history of malignancy, or the patient is sepsis, or whether patient is cavity lesion, chances of being MRSA. That part also we have to see before de-escalate the antibiotic in these cases.
But in this patient which we are discussing, it's a simple mild CAP. Maybe we can de-escalate. I would
de-escalate.
Yes, I would stop probably. Okay, I stopped the antibiotic, and in a couple of days, Dr. Arnab, patient deteriorated. Now he's requiring NIV support. He's having respiratory failure. oxygen requirement has increased and we are shifting the patient to ICU. So do you think this is now presentation of severe CAP, and how do we define what are the criteria, and is the management now different from usual CAP, or like how we manage this patient?
The problem is that now you have diagnosed it with a viral pneumonia, and now the patient has been deteriorated. So there is two, three options. So probably a viral pneumonia can win into, ARDS kind of thing. So that's why probably the patient got deteriorated. Okay.
Right.
So the management would be different. Okay. Yeah, the patient may go into, kind of heart failure with a preserved ejection fraction kind of thing. Maybe a elderly patient can have that problem also. So you have to manage that accordingly. And there is a possibility of, secondary infection kind of, the patient is in hospital, so there is a possibility of that. So that's why I'm asking that we need an initial good sample. Okay, that is the important part. So we can be confident about it. But let's say take it as a severe CAP, and probably there is a chance of, there is a bacteria or superadded by some kind of viral infection, and now the bacterial infection has been deteriorated. So if the patient is in severe CAP, so depending again on, the local, antibiogram, the local endemicity of the organisms, the resistant pattern, you have to change your antibiotics accordingly. So you can move up into, penicillin, tazobactam, cefepime, or meropenem kind of thing, depending on your local resistance pattern, and definitely you can add MRSA coverage for that. So you have a viral pneumonia followed by worsening. So probably post viral infection, MRSA infection can be there. So you have to change your plan accordingly. Okay, so that would be my point on this case. Okay.
And what about steroids, sir?
Definitely in severe CAP, you can add steroids. So it's a Cape Cod trial, nice trial. So the patient if the patient comes with, severe CAP, the criteria is matching, you can start. I usually routinely start in a severe CAP patient. But definitely then again, the point is you have to, if there is influenza, there is a, controversial thing using steroids in those kind of patients. Okay.
Correct. And HFNO, do you routinely use HFNO or NIV is preferred?
Yes, for severe CAP patient. So depending, say, work of breathing. If the work of breathing is quite high for the patient, so definitely we can go for the HFNO. If the patient is in type 2 respiratory failure, you can switch to BiPAP. And depending on clinical situation, if the patient on BiPAP is severely tachypneic, the axillary muscles are working, then the overall criteria, as per criteria, you can go for the ventilation.
Even the availability of HFNO is also a big issue. Like we have NIVs only, so we start our patients on NIV most of the times.
Most of the time, yes.
Okay. So I hope with this management that CAP patient further survives. So because we have to move to the another section, that is hospital acquired associated pneumonia and ventilator associated pneumonia. So we go with the second case, and this is the case of a 60-year-old male who underwent emergency surgery for perforation peritonitis, and he required mechanical ventilation post-operatively and was in ICU. So on day 3 of ventilation, he develops now fever, rising leukocyte count, and purulent endotracheal secretions. I think this case is also similar to what Sir presented. And now his chest X-ray is showing new infiltrates, and the patient requires now more of oxygen. So I'm coming to Dr. Ambika. So now this case is there. So can we call this as VAP, or is it, there are so many terms which are very confusing. VAP is there, then VAT is there, then VAE is there. So do you think this fits into that, any of the criteria?
So seems like today I am the one who is doing the case solving. So, but yeah, this seems to be more easier than the previous one where we have to do the risk stratification. So if you see this case, he has very typical presentation, what you have been mentioning, that this patient has been ventilated for 48 hours, now develop a new onset fever, have leukocytosis, purulent secretions, and what you want else is the new infiltrate on chest X-ray, patient's oxygen requirement is increased. This all fit in the ventilator associated pneumonia category, and we can call this a VAP. We should not call it a ventilator associated tracheobronchitis. A little difference is here that patient has a pneumonic patch on chest X-ray, which we usually don't see in patients with ventilator associated tracheobronchitis. Another important term which you say is a ventilator associated event. This will come under the event. This this term is predominantly used as a surveillance, where we any the patient who is on ventilator and has a worsening hypoxemia, increase of IOT requirement or increased PEEP requirement, then we look for the causes, which can be infective, which can be VAP, or it can be, non-infective, non-VAP conditions also, like, maybe atelectasis, the secretions are blocking. So VAE includes both VAP and other non-infective causes, but predominantly in the practice, what we are concerned about the VAP and VAT uh, to manage the patients. So I think I have included most of the diagnostic criteria, but there are the scoring systems, CPIS and other, when we are diagnosing VAP. I do in, we don't have a separate a closed ICU, so the treating physicians usually diagnose their cases with VAP themselves, and the busy OPD or busy ICU, what we do, we see grossly the patient, that what is this patient intubated for more than 48 hours? Is there a new patch, or the previous lesions has been increased in size? And then we see the oxygen requirement. Is it increased for this patient? If the patient's counts were normal earlier and is now increased or decreased, patient is spiking fever, which wasn't there. If there is loss of purulent secretions coming from ET tube, that all suggests that patients are going towards a ventilator-associated pneumonia. And not to forget that whenever there is a secretion, we have to send the sputum, not in this case sputum, the ET aspirate, or if there's not the ET aspirated not much, one can go for the BAL or protected brush sampling to confirm that what bug is there, because for VAP, probably we will be needing to change our antibiotics. So yeah, so this is how we diagnose and practice that ventilator-associated pneumonia, predominantly more than 48 hours, new patch on X-ray, and clinical duration. Yeah.
Correct. And can you please tell me how to prevent it as well? I have two questions for you.
So yeah, we've been talking about VAP bundles since our PG days. There are little modification keeps going, changing over the time, but I just remember all of them, or maybe I keep on adding or minusing some of them. Maybe you can update me if I'm not that updated. But again, as a practical approach, what I keep is keeping the patient's head and elevated, and daily sedation interruptions, trying to extubate the patient early or do the weaning trials early, and everyday assessment for, if we can extubate this patient's oral hygiene should be taken care with the chlorhexidine. Subglottic suctioning can have an important role. Not to forget strict hand hygiene, which is it all the 5 movements of hand washing should be followed in patients who are on ICU or on ventilator. And one should avoid unnecessary ventilator days. Patients should be mobilized quickly. And most important, I would say, don't just put patient on ventilator directly. Now we have a really nice modalities, NIV is doing magical, HFNC is doing good. So these trials should be given to this patient before considering them for putting directly on mechanical ventilation. And yeah, we used to also give the stressors of prophylaxis, like giving PPIs and DVT prophylaxis. So these are some 8, 9, 10 points. I know some are outdated, some are included, but yeah, they all have important role in preventing VAP.
Okay. Very, very nicely put. So we don't have much time now. We have to be a little faster now. So to Dr. Madhukar. So suppose if this patient was in your ICU, would you like to say that what bug you would be suspecting? And indirectly, I want to ask that what are the bugs that we suspect when the patient develops HAP or VAP in our ICU in Indian scenario?
Yeah, we already know the common organisms associated with VAP, and these have already been elaborated. It could be ESBL, Enterobacteriaceae. It could be, the Pseudomonas, can be MRSA. So even can be Acinetobacter. But everyone should have a surveillance report with them for their ICU. What kind of bugs they are having most commonly in their ICU. As Dr. Arnab was talking, he is seeing more of Acinetobacter. I am seeing more of ESBL positive Enterobacteriaceae. So the local surveillance, their own ICU surveillance report is important. to say that what kind of bugs they are commonly going to see in their patients with VAP.
Okay. And are there any infection control practices and like what antimicrobial stewardship programs do you run at your center to prevent this resistant bugs?
Yeah, Dr. Komal, it's a great question. I mean, this is something really, really the core of the, the VAP management is. The antibiotic stewardship is really important when we want to prevent the emergence of the drug-resistant pathogens. And the most critical step, I believe, is the de-escalation from the empirical multiple broad spectrum antibiotic to the single narrow spectrum antibiotic based on the culture report you are getting. So the most important step becomes sending the sample for microbiology before you start the empirical treatment. The second is your empirical treatment should be appropriate and adequate. What does it mean? Appropriate means you have the surveillance of your ICU and you know what kind of antibiotic as an empirical treatment you're going to give these kind of patients. I'm just putting an example. For example, if in my ICU it's ESBL positive Klebsiella is coming more and more, then I would definitely not keep the third generation or cephalosporins as a part of the empirical regimen. So this is how it works. And the
Right.
second, it has to be adequate. You know what antibiotics you are using? These bactericidal antibiotics can cause concentration dependent killing or can cause time dependent killing. So the adequate antibiotic means, for example, if you're giving meropenem, you have to give a longer infusion time. So
Yes.
this is important, again, a part of, antibiotic stewardship. The third is the duration of antibiotic you are using. So in most cases, as we've been listening throughout, in most of the cases, we'll limit the treatment to about 7 to 8 days in VAP, except in certain circumstances when you have Pseudomonas or Acinetobacter or certain other comorbid conditions that, for example, a structural bronchiectasis patients growing Pseudomonas, we wouldn't be stopping it for after 7 days. So these are the things that come into the antibiotic stewardship. Rest of the things, I believe, hand hygiene is really, really important to prevent the cross infections. Rest of the things Ambika already told, but contact isolation is something we should be looking into. To summarize, Dr. Ambika, as you went ahead with the bundle, I'll again include that bundle in this. So this is something that we should look into to prevent the emergence of these resistant pathogens. Thank you.
Excellently put, sir. You have pointed out every single point very nicely. And I would like to add here that we have been doing antimicrobial stewardship very vigorously at our center, and that was my thesis also when I did my ID from CMC Velo. So what we did was we did prospective audit and feedback. We started applying that, and before applying, like for 3 months, we collected the data of the antibiotics being used. We applied prospective audit and feedback in our ICU. And after that, we did 3 months data. And we could see that the use of meropenem had dropped to very, very much significantly. And the length of stay and mortality remained the same. So without compromising the outcome, we could actually decrease the use of meropenem. And it was a and it was a very good study that we could actually present at ERS also. So prospective audit and feedback is a very useful thing if we want to apply antimicrobial stewardship in our
Yeah, that's a
center.
great message, Komal. I mean, everybody who is working in the ICU should have their ICU microbiological auditing done routinely so
Yes.
that they can have an idea of what empirical treatment they are going to start in their patients.
Correct, correct. Absolutely. We have a question in chat box also. So, Dr. Utkarsh, I want to ask about this thing that now this patient is there. Are you going to send the samples from ET secretions or are you going to perform BAL in him? Is there any difference between sending the samples by ET or BAL or bronchial brushing, or you want to say something about it?
So, for this patient is on, I would like to do bronchoscopy at the earliest, preferably prior to bronchoscopy, if it is possible. I could send an ET aspirate if there we don't have a bronchoscope or we are at the time that patient is not stable for a bronchoscopy because of any other comorbidity. So I think bronchoscopy should be done, and we can localize if there is a lesion in any of the particular lobe, and we can take a specific sample from that lobe and send it for the investigations. And moreover, I would like to send this sample for molecular diagnostics biofire, so that at the earliest we can know what resistance pattern, what organism that we are dealing with, so that antibiotic could be specific for that. We can start as per the empirical based on the molecular diagnostics available. Right. So I would prefer doing a bronchoscopy. However, if I talk about theoretically also, bronchoscopy bile cultures have a higher sensitivity as compared to an ET aspirate if we are doing.
I would like to disagree at this point. Probably, even Dr. Madhukar wants to say something, but let me put it first that what I have read and experienced is ETs, the sensitivity is not higher or lower, but we can get the quantified data if we are sending the bile sample rather than being less or more sensitive. Yeah, if there is collapse of lung or something like that, we can definitely go ahead with bile. But first, I think ET should be enough. Yes, Dr. Madhukar, you were saying something.
Totally agree. I mean, it is technically easy to do. It doesn't take time. You know, your treatment decision won't be getting delayed. You're going to get the report of gram stain very fast. You're going to get the report of culture at least by 12 hours before, if you plan to do a bronchoscopy. But since the esteemed panelists are here, I have a different perspective to see into it. I mean, what I'm seeing into it. For example, in your case, your patient has peritonitis. Do you believe that your patients hadn't uh, uh, got IV antibiotics before coming to your hospital?
Yes,
So
he
he
must.
must have been administered an IV antibiotics. And if a patient who has been earlier have received antimicrobial before, how much do you rely on the quantitative data that you are going to get from either ET spirit or from the bronchoscopy? Whatever the dictum is, we say that we should, for BAL, for example, we should take 10 to the power 3 instead of 10 to the power 4. But these are all expert opinion. We do not have a validated data. Now tell me, if your patient is having clear-cut pneumonia, and even if you are having a quantitative, aspirate positive, not qualitative, which is indicative of pathogen which are usually implicated in VAP, wouldn't you consider it as a causative organism and go ahead to
Right.
treat this?
Yes, absolutely.
So if anybody, this is my, kind of
Maybe we can ask Dr. Arnab because, sir,
It all depends on which setup you are working on. So
correct.
in my setup, it's a kind of, what you are getting NDMs, oxas, so I need a, resistant patterns, and sending a bell sample with a, kind of biofires, we get a definitive result and within 24 hours that which
Correct.
antibiotic would be
All
approved.
right.
So in my
So do you
setup,
do mini bal? Do you perform mini
yes,
bal or
we perform minibel also, but if my bronchoscope is available,
you do bronchoscopy?
we do.
Moreover, sending a ET aspirate or mini ball for an biofire investigation, which costs 30,000 for the
Yes,
patient,
yes.
you can't risk it with it. So you
Right.
need a very
Absolutely.
good
Yes.
sample because you are doing a hefty, costly investigation.
Correct, correct, absolutely right. So with that, we are now at biofire level. So in this patient, as Dr. Utkarsh said, we did bronchoscopy, we sent the lavage. So obviously we want to send it for biofire or molecular testing. So Dr. Abhishek, can you please guide us about what do we see in biofire, what organisms they give, what genes we can see, and is it actually better than culture? Sir, you are on mute.
Biofire. First, I would like to tell the advantage of biofire over the culture, man.
Okay.
Ma'am, definitely biofire is more sensitive than culture. But if we go for the specificity, culture is more specific. There is high negative predictive value with the biofire. But in case of biofire, the difficulty is that it detects both the dead and the live bacilli. So we cannot be specific. We cannot tell this one that the bacteria is which we are getting is the organism which causing the infection. So we have to correlate clinically also. And if we have the culture report on the best culture report with biofire report, it helps us more. Again, the biofire, we have the turnout time is small. Within 4 to 5 hours, we get the reports. It helps us in early taking the decision on the antibiotic. And in most many times we see a lot of organism we get positive. As Sir has told, sending biofire early helps in getting the organism. We do not get the OT, our ICU organism with that one in our biofire false positive reports. So sending biofire early usually helps us, and if we can get the organism like here Klebsiella, this Enterobacteriaceae we can get, then we can have a Enterobacteriaceae usually we get our in our case. Then from the genes we know oxagen we can have NMD, we can have then ESBL we can have from the BAL, we can have methicillin resistance pattern we can have based on the BAL. Then from the BAL we can this one from this one with from the this one our biofire we can also have about the MRSA pattern, Staph aureus, Pseudomonas organism. About 15 to 20 bacteria, typical of typical bacteria we can know from the BAL, this one biofire. And usually we should try to give deep endobronchial secretion lavage, or we can have bronchial lavage. Either of two we should send. Sending the proximal endobronchial sample usually maybe not good for the patients, and it is costly test.
Very well put, sir. And I just want to add something. When we are sending the biofire, there are so many companies who claim that they are doing this molecular test. We must know whether this is authenticated or not. The lab is authorized for doing biofire or not. Because if you see, there are so many people who come with their menu card that, ma'am, we do 16 bucks and we do 20 bucks, and somebody was telling me 40 bucks, but they do not. That day, some person came with the NTM PCR in the same biofire, but we don't know even the sensitivity. They are not able to answer that. So we must know where we are sending the sample. And second, one important thing, that in biofire also we get the colony count. So if the colony count is high, that means it is not a colonizer but the actual infection. So it is a very important point to note. When we are sending the biofire, we can actually say that this is not a colonizer but an actual infection. And that's why biofire has become a very, very important test in nowadays, because we can see the bug, we can see the mutation, and we can just start the antibiotic in our patient accordingly.
So, Dr. Komal, just one thing. I mean, doing biofire in ET spirit, then doing biofire on BAL sample.
Yes.
How does it make difference clinically to our clinicians,
So maybe we get better samples. So logically, it should get a better yield, but there are no hand-to-hand studies on ET and BAL for the biofire itself.
As far as
I'm more confident if the sample is lower respiratory tract.
Yeah,
respiratory sample we need.
Yeah, but as far as I remember, the difference between biofire and ET spirit and BAL is something that differentiates colonization versus infection. In any way, we are going to get the quantitative PCR. And also, I do particularly believe that in a patient who is having pneumonia and a pathogen which is being detected is presumed to be the causative agent, it doesn't make much sense, it doesn't make much difference. So I believe that coming to all these questions combined, I will go for the ET spirit. I wouldn't think much of the quantity. It's even qualitative is important, and biofire multiplex PCR, whether BAL, whether ET spirit, it is going to help us.
Okay, point very well taken. So now we have sent the BAL. अभी तो उत्कर्ष ने बोला, तो we have sent the BAL. And by the time, sir, Dr. Arnab, sir, what should we start on this patient? This is a case of VAP.
Because time is short, I should also be quick. So it all depends on, so theory and, practically what we are doing, probably it's a little bit of kind of differences there. So probably if there is, kind of your hospital has a 10 to 20% of, MRSA, if you see if the MRSA incidence, so probably you have to add a MRSA coverage, definitely. And another important point, you have to see if there is a kind of pseudomonas resistant pattern is more than resistant pseudomonas is more than 10%, definitely have to add 2 anti-pseudomonal coverage in this case patients. So preferably, definitely I can add you kind of meropenem or cefepime or piperacillin tazobactam kind of thing. But if it happens in my eye soup, I know the bugs. So preferably my option because I usually see CRKPs, I mean carbamazepine resistant Klebsiellas and Acinetobacter. So my thought process would be the patient has deteriorated, so let's start ceftriaxone and
Ceftazidime.
Astrodome combination, okay. Or if I am thinking of Acinetobacter, polymyxin, or sulbactam or minocycline, whatever.
Yes, yes.
So that thought should be, patient to patient basis, in what hospital you are working, in
Correct.
what ICU you are working. All depends on.
Absolutely. That's why we must
Yes,
have our
recovery is
antibiogram,
happening.
and without antibiogram, we cannot treat our VAP. We
Yes,
must have it, and we must keep updating it.
yes.
Very well put, sir. So coming back to Dr. Ambika, nowadays we are seeing so many terms like MDR, XDR, PDR, DTR, all about gram-negative bacilli, not about the TB that we we used to love. So now, can you please tell us what are these terms?
I'll go with the easy one first, which is PDR, or we can say TDR. Also, this is total drug resistance or pan drug resistance. That means the organism shows resistance to all available antimicrobial agent across all classes of antibiotics, which are predominantly the beta-lactam antibiotic, aminoglycoside, fluoroquinolones, and carbapenems. So in this particular group of patients, it's very difficult to treat them, and sometimes we just use the combination treatment and experimental drugs for this particular category. Now coming to the MDR, where it is the bug is not susceptible to at least one agent in 3 or more antimicrobiological classes, which I just mentioned. Coming to XDR, XDR means the bug is only susceptible to one or maybe two antimicrobial classes, and it is resistant to almost all other bugs. Yeah, so these are the MDR,
And
XDR, and PTR.
that is one term as difficult to treat as well, DTR.
Okay, yeah, this is also interesting term. Difficult to treat resistant bugs are actually the bugs who are resistant to all first line drugs, and the most effective drugs, which are we consider that they are low toxic, and we should consider if we are looking for this bug, we should treat this patient with this antibiotic. But these bugs are resistant to these antibiotics, and they are probably susceptible to older toxic drugs, which are like aminoglycosides, maybe polymyxes. So this is a unique terms, and yeah, they have a susceptibility, but predominantly to the toxic drugs.
Right, absolutely. The term has come new, like in 2018 only they started the term DTR, and mainly it is for carbapenem and extended spectrum cephalosporin resistant. They are also resistant to fluoroquinolones, probably. Okay, so to Dr. Madhukar again. So now this patient, we sent the multiplex PCR, and same like Arnab sir, it has come as Klebsiella pneumoniae with NDM gene mutation. So can you tell me about the mutations of CRE, like OXA, NDM, KPC, all
Yeah.
the mutations? Can you tell me
Dr.
details
Kamal,
about
for lack of time, I'll just touch what Dr. Arnav has already taled about. So these are the gene mutational gene we when we are concerned with the CRE. So it's a kind of carbapenemase producing gene which causes resistance. So OXA is the one. Then we also have KPC and also this NDM. So he has already elaborated. NDM is really a tough one. It's a group B one, and where we need ceftazidime with avibactam and also estrionam. For both OXA and KPC, group A and D kind of, where we need just ceftazidime and avibactam. Thank you.
Yeah. What about cefiderocol?
I haven't used it.
Sir, Arnab sir, have you used cefiderocol in your patients? You haven't used. Okay. So, Dr. Utkarsh, to that we are coming to the new antibiotics. Can you tell us something about newer generation antibiotics like ceftaroline, ceftazidime or tazobactam? Then there is cefiderocol.
So I'll take them individually because these are very important drugs as of now, because now every day we are encountering these pan drug resistant isolates with us. So ceftazidime, avibactam or ceftriaxone, tazobactam, These are beta-lactam, beta-lactamase inhibitor combinations, and ceftazidime avibactam is particularly effective with KPCs or OXA type of carbon and with the carbapenem-resistant Enterobacteriaceae infections, which we are increasingly seeing in our ICUs these days. In last 3 to 4 years, if I talk about, there are increasingly we are finding these. Ceftolozane tazobactam has a very good activity against the MDR pseudomonas and in VAP with where pseudomonal resistance is suspected. So we can use this drug over there. So I also haven't used cefiderocol, but I'll say this is a kind of a cephalosporin. It is a sidrophobes cephalosporin, which we are using in a carbapenem-resistant organisms like Acinetobacters and Pseudomonas, or where CRE infection is there. So this is basically a kind of a salvage option for gram-negative organisms. Then,
Pseudomonas, preferably Pseudomonas and other organisms also.
yeah.
Yes, definitely.
Then the next one was the tedizolid. Tedizolid is a newer oxalizone, and this is preferably against MRSA that we are using. It's a kind of a safer adverse reaction profile as compared to linezolid.
Correct.
And I think lemonidafloxacin, we all must have tried at least once till now. It's an Indian.
Anti-MRSA coverage.
Yeah.
Yeah, it has
So it's
anti-MRSA.
anti-MRSA. Yeah. So this is one.
Okay, very well put. So I'll be very quick with last two questions, Dr. Abhishek Agarwal, sir. So the question is that now any role of adjunctive in a nebulized antibiotics like colistin in this patient?
In nebulized, this one antibiotics we have three: tobramycin, amikacin, and colistin. We have used in our clinical practice, but only tobramycin which is available in the nebulized form. The colistin which we are using, the injectable colistin we are using for the nebulizer in the nebulization form, in the antibiotic form, but in the nebulized colistin is not available. Injectable colistin is being used for this one. In gram-negative organisms, they have definite role because it's achieve high lung concentration with low systemic toxicity, and again it gives better clearance of the bacteria, especially in the cases where the chance of in IV antibiotics are toxicity is high, like in renal cases, or where that there is resistance to bacteria, multiple drug resistance of the bacteria is there. So in that case, we have the advantage of using the nebulized colistin, which have its own challenges while using the colistin in nebulized form.
Okay. Thank you. Very well put, sir. And the last question to Arnab, sir, that the guidelines say that we should stop antibiotics at the 7th day. We have seen in your lectures also, Ambika, and you put it very well that we should be judging clinically. But that's just in this patient. We have started with polymyxin probably, and then how long are you going to continue with that antibiotic?
Even if it is a Acinetobacter, then even that at that time I can preferably stop it at day 7 if you know for which you are giving the antibiotic. So the the pneumonia, the oxygenation has improved. So if the patient is in shock, the shock has been improved. Okay. And if you send procalcitonin, if there is a 80% reduction in your procalcitonin level or it is less than 0.5, then you can definitely stop it, but definitely have to think of other conditions. So if there is a kind of empyema, if the patient is immunocompromised, if the patient is slow responder, okay, then you can continue the antibiotic prolong for even 10 to 14 days also. But you have to keep that mind with this polymyxin B, there is a risk of neurotoxicity, nephrotoxicity, these kind of things are there. And just to talk about another one, you can see Komal in the chat box also. So probably you are told now the BioFire has a kind of colony count. This is not colony count actually. These are gene copies per ml. Okay, so this a little bit different from the colony count. Okay, so there is gene copies. So the important part is that though if the gene copies per ml is almost more than 10 to the power 6 to 10 to the power 7, so it is clinically significant, and if it is 10 to the power 4 or less, so probably these are colonizer. So this is a little bit difference from
colony count. Yes, absolutely, is a very valid point, sir. Yes, very nicely put, sir. And there are a few more questions in the chat box. So one question is by Dr. Indu Bubna, ma'am, and I'd asked Dr. Madhukar to answer that. So she's asking about MDR Pseudomonas colonization. The patient is already a known case of bronchiectasis, so it's a long case that she has typed. So, how do you treat this patient, as a community acquired pneumonia guidelines, or as per bronchiectasis exacerbation protocol?
Yeah. So when she is talking about colonization, I believe she must have found two samples positive at least 3 months apart in bronchiectasis patient who has not exacerbated in these period of the time. And this is what the colonization means. And if this colonization is MDR positive, then to treat the colonization, we have a second line options of giving inhaled antibiotics or macrolide. So inhaled antibiotics doesn't take consideration of the culture report or culture report resistance. So even if the patient demonstrates resistance to the aminoglycosides on culture, then also the patients are should receive inhaled aminoglycosides. It doesn't make no difference at all, because in colonization the aim of treatment is not the eradication. In colonization, the aim of treatment is the prevention of exacerbation. So even if the culture report shows resistance, do not hesitate to go ahead with inhaled nebulized aminoglycosides and see after an year if the exacerbation is going down or not. Thank you.
Okay, very well put, sir. There are many more questions. I'll quickly go. Dr. Tridip Chatterjee has asked about biofire that we have already answered. Dr. Sai Chakravarti is asking, should we send blood culture in addition to sputum cultures?
I'll take this one. Okay. So yeah, I was presenting, and in my presentation also, when we think about severe CAP, when we are suspecting patients having pseudomonas or MRSA infection, so guideline when they are describing that send the sputum samples and also send the blood culture sample. They don't mention that when you're sending the sputum sample, so wait for that or then wait for the blood culture to be sent on the next visit. But I think in the clinical practice, sometimes when we send the sample, when we get a good amount of sputum samples, we send the sputum samples, and we get the answer from there, and patient response, we don't send the blood culture. And if the patient is not responding, and maybe in the next visit we are doing, but the guideline says that you can send both the sample, the sputum, and it can additionally tell us the invasive pattern of the bacteria and bacteremia also. So yes, and another question also I can see I can take for the CAP question, which they have asked about what percentage of pneumonia do you have identified in causative agent. If we see the guideline, it again says in less than 50% of cases we are able to identify, and then it depends upon the resource limited setting, where are you and you are doing what test. And in our country we have already subjected patients to antibiotic before they come to the hospitals, and we always get the negative cultures even with the
See, even in the famous EPIC study, there were 30% of patients where they could not diagnose the cause of pneumonia, right? Okay. There is one more question about mucormycosis that we are going to cover in the coming sessions, obviously. There is one question by Dr. Srija Nair from Bombay, and she's asking what is the difference between NGS and biofire. Can Dr. Arnab Bera, sir, maybe you can ask it better and you can answer the better. What is the difference between NGS and biofire? Other than colonic count or whatever gene copies.
Am I audible?
Yes, sir.
So BIFAR is also all or kind of PCR techniques. Okay, so NGS means next generation sequencing. It's a kind of hybrid thing. Okay, and in BIFAR, which is routinely available, but you have to see what you have. The Komal has also. There are lots of people are coming with this kind of NGS BIFAR. We have kind of pneumonia sepsis PCR panels. So there are different kind of things, but you have to, important part is you have to collaborate with every time with your culture reports. What we also do, we always collaborate the reports with our culture reports. So the company from which the culture reports are collaborating, then you take that report in a sense, that method in a sensitive way. All other there are multiple companies. I usually meet 5-10 companies every day from different kind of they are coming with this sequencing, next generation this sequencing. We do this kind of sequencing, but definitely always collaborate with the culture. So these are the hybrid models.
So Dr. Komal, the basic difference I believe is with multiplex PCR or biofire, we have identified pathogen primer. So we know that, for example, we are going to test for 16 bacteria and 23 gene for resistance. But in NGS, we do not have a predefined primer. So it will detect every bacteria
Every.
present over there. And this is why NGS takes a slightly longer time, for example, of 72 hours or something like that. NGS is a protocol in the research setting when we are trying to find more and more resistance. So it's not clinically useful at present, but biofire is clinically useful. This is the basic difference that I see between NGS and biofire. Thank you.
Yes, sir.
Dr. Utkarsh also wanted to add something here, I guess.
No, I think Dr. Madhukar has said what I was about to say. So he has briefly summarized that NGS is for the research purpose. It takes longer time, and biofire is something that we can use for the clinical purposes. And culture is always important. We should send culture despite sending anything, and despite taking off the biofire reports. Culture should be followed. Whatever is being isolated, that is 100% specific thing. So we should go for that.
Absolutely, absolutely. So with that, we conclude our session. We started with saying that CAP, HAP, and VAP beyond books. So I hope we gave the exchange of knowledge beyond books, beyond theory, beyond guidelines. Can anyone, I would want all of you to put one thing that you learned something new, or you thought that, okay, we can do this better this way. So I'll start with Dr. Ambika again.
I think I became wiser about NGS, biofires, and I agree here that many of the things which was brought just in last 15 minutes I didn't knew much about that. Yes, so that was an interesting thing I came across.
Dr. Madhukar.
Yeah, thank you, Dr. Komal. I'll take this platform to say that please use antibiotics judiciously, appropriately, and adequately. Thank you so much.
Dr. Arnab Bera, sir.
So definitely, probably you have to use your antibiotic judiciously, because every time a patient admit in ICU for whatever reasons, be it heart failure, be it some surgical case, pure surgical case, or any COPD basic exacerbation, everybody is getting antibiotics. So definitely you have to give your antibiotics appropriately, and everybody should in their hospital, antibiotic stewardship program should be initiated in every hospital, so that this kind of resistant bugs, definitely we can see a fall in them in near future. Okay.
Dr. Utkarsh.
So everyone is talking about antibiotics, and we all focus on starting antibiotics. We never think about de-escalating antibiotics until or unless we are 110% sure that patient is improving. So early signs of improvement should be followed, and de-escalation should be done based on if our cultures are negative. We should narrow and de-escalate the therapy and limit the duration of antibiotics also, as per the clinical judgment.
And Dr. Abhishek, sir.
Point has been covered by the panelists. I would like to say, before studying antibiotics, we should know with the hospitals, we should also know our regional antibiotic biogram. Because our hospital antibiogram we know, but we often see that in every region has different antibiogram. And the patient which we are receiving, whether we are a tertiary care center, secondary care, or primary care center. In a tertiary care center, usually we receive patients very late who are already taken antibiotic for more than 5 to 7 days. So we should be very judicious while using the antibiotic, so that we do not lose our patient also. Delaying the giving antibiotics just only to follow this one following the protocol as per guidelines.
Yes.
That should also be kept in mind.
Absolutely. So we should not just follow protocols blindly, but use our clinical acumen. We should also look at antibiogram, regional, also in our hospitals, starting antibiotic early, de-escalating on time, using markers like Procal, Biofire, everything. So that way, ultimately, we are trying to inculcate antimicrobial stewardship in our day-to-day practice. I think that is the main crux of this entire discussion. And I would like to thank the entire CCI team and this beautiful group of panelists. You have been wonderful, all of you. And I think last question has come up. If anybody wants to take. Pseudomonas colonization, but no previous history of structural lung disease or prior Pseudomonas infection.
So I probably so you have started on basic antibiotic. Okay, so probably as a community acquired pneumonia, you have started coamoxiclav and azithromycin, and the patient has clinically responded well, and you got a sputum culture report with a pseudomonas. Okay, so do you treat this? No, definitely.
No.
If the patient is clinically improving, there shows clinical signs of improvement, you don't go for the culture reports. Okay, so even the culture shows a resistant organism, you just continue your ongoing antibiotic therapy. If the patient is clinically improving and the count CRPs or other inflammatory markers are decreasing, you just hold for it. Okay, don't go to treat that.
Correct, absolutely. Thank you so much, everyone. I took more time than we decided.
So it's already more than 2 hours.
But it was a very, very nice session. I really enjoyed moderating this session. Thank you. Good night.